Good morning, everyone. Thank you all so much for being here. This is really an incredible milestone for me. My name is Abby Reese. I'm a certified nurse midwife. I'm a doctoral candidate at the College of Nursing in the Health Policy concentration, and I'm a Robert Wood Johnson Foundation Nursing Health Policy Collaborative Fellow. And I'm here to present my dissertation research entitled Trying to Cover the Sun with Your Thumb, a Critical Ethnography of Maternity Care Provision in Rural Northern New Mexico. I could spend the entire 30 minutes on this slide alone. I have so much to be grateful for, and I have received help from so many people. You've been introduced to my committee, a truly interdisciplinary collaborative effort, which is something that I actually philosophically believe in so strongly, and I'm grateful for all their assistance. And I also could talk for more than half an hour about everything that Dr. Kim Cox has done to mentor me, guide me, and support me through this process. So just know that I'm incredibly grateful for that. None of this would have been possible without the Robert Wood Johnson Foundation, which funded my research and my education, and truly has put forth a model of a place for nursing at the table. And my family has sacrificed a lot over this process, and my husband is here, and he will continue in his role of keeping me on track, so don't worry, I'm paying attention to the time. More than anything else, I want to thank the people who participated in this study. People gave me their time, their insights, and their trust, and I hope to honor that right now. So the title of my dissertation project was provided to me by one of my participants. And during our interview conversation, she said, to me, it's how do we create a different solution? Because thus far, the solutions that I've heard or read about or researched about are all about how do we increase the number of providers. And I feel that is like trying to cover the sun with your thumb, as we say in Spanish, you know? And I felt like when she shared this dicho with me, she was offering a critique of a very narrow lens to this issue and challenging me to think about things in a broader way as well. So again, this is something I've tried to do, and it matters. We have more than 28 million women of childbearing age living in our rural communities, but more than 40% of U.S. counties do not have maternity services. Maternity care services are also increasingly centralized in metropolitan areas. That's been documented, and even over a recent 2-year period, 14% of U.S. hospitals that had very small services, fewer than 100 births a year, closed their units. And these tend to be in the most remote rural communities, so there's a geographic implication to that. Rural provider shortages are pervasive, and they're worsening. Only 6% of OBGYNs practice in rural areas. And then over a decade, the number of family physicians attending births dropped from the already low 23% to about 10% last time published numbers that I'm aware of. And the role of midwives across states is inconsistent and not super well documented. And this slide is just here because I want to be clear that maternal and infant mortality are multifactorial issues in this state and across our country, but there is evidence to suggest that decreasing access to maternity care services is associated with specific outcomes that lead to these catastrophic results, higher rates of preterm delivery, and we also have some evidence from the CDC that these rates are rising a little bit faster in New Mexico than they are, nationwide. Although numbers remain small, this is something that we need to address. Maternity care in New Mexico. New Mexico is the 5th largest state in terms of geography. We're served by 28 hospitals. 3 of them are federal Indian Health Service facilities. 8 of them are in metropolitan communities. So really we're talking about 17 hospitals that serve, in general, our rural communities. And really more than a quarter of the counties in New Mexico do not have hospital-based maternity services. We have lost maternity services in 4 rural hospitals since 2010, and only one of them has reopened. It was really portrayed as a temporary closure. The others were permanent. But we do have strong midwifery traditions that influence current practice. Especially those in the midwifery community are aware that there was recently a large study published that tried to quantify the integration of midwives in the US states and determined that New Mexico was ranked #2 for midwifery integration, and that this was important because midwifery integration was associated with lower adverse outcomes, including neonatal death. So they're trying to look at, what does integration look like and how do we promote this? My findings have some response to that ranking and things to really keep us on our toes and think about. And it's also important to note that Medicaid is the primary payer for 72% of the births that happen in this state, which is the highest of any state in the country. I put this slide up here to let you know this is the distribution of the OBGYNs compared to benchmarks by county in New Mexico. This is 2016 data. The New Mexico has, based on a law that was passed in 2011, really some of the most robust healthcare workforce data collection in the country. And this map is one of a number that are published annually. In fact, we're probably due for a new report within the month.
October 1.
Okay, so we'll have 2017 data coming. It's incredibly important that we have this data and that not only, especially for some provider types, since we've been tracking it for a few years now, are able to look at trends in terms of the location of service providers. However, there's inherent limitations in this data. Specifically as regarding OBGYNs, we don't ask physicians if they catch babies. So we know that there are OBGYNs located in places we do not know exactly what services they provide. Oh dear, flinging my arms around. That's great. Sorry, you guys. Wow. How do I deal with that? That's so typically Italian of me. Yeah, flinging my arms around, right? And I.
Go ahead.
Yeah, Brian.
Are we done?
We're just,
We
I
do
think
have
I've
new
just
candidates.
Okay. Sorry, everyone. I'm gonna move to a safer distance for my very small wingspan. I also want to share, starting last year, we started collecting data for nurse midwives and licensed midwives. I'm not aware of any other state that's doing that on par with data collection for physicians and other advanced practice clinicians. I think one thing I want to point out about, I could say a lot about these maps, and I know I've really limited time. This data was published at the time that the hospital in San Miguel County, one of my focus counties, was closed. And this map cannot reflect geography. It doesn't really reflect the pathways where women have to go or where they do travel for services. But these circles here, no surgical facility in county is the blue, and the red and white is no inpatient maternity service. I don't remember off the top of my head, but this is about 9 contiguous counties and many, many miles. And one of the questions I have is, does our state legislature have any vested interest or anything to say about having about a quarter of our state with a more restricted array of services? So these are some of the questions that influenced my work, but this is quantitative data, and I am a qualitative researcher and ethnographer, and I wanted to add some texture and some context to these really important data and numbers that we have. So these counties outlined in blue are the places where I focused my, my data collection. Why those counties? Well, I had to, thank you to my committee, by the way, for this insight. I couldn't study every county, and I really appreciate the guidance there. These are counties that have, each one of these counties has hospital-based maternity care, actually organized under a different ownership model: county ownership, corporate ownership, nonprofit statewide network ownership. All provider types are represented in some form or fashion across the area. There's strong historical context in these communities, some shared threads, some distinct features, and some real significant health challenges. And the referral pathway for higher risk care kind of follows the same pathway and same funnel down to where we have, tertiary care available here in Albuquerque. So these were the places where I did my field work and my interviews, and these are my research questions. I wanted to look at the barriers and facilitators of rural maternity care practice, and I was looking at structural, institutional, and personal relational considerations, and I'll explain that a little bit more. I wanted to look at our current policy and training approaches and see what impact they were having on providers who are in place. And I also wanted to look at the significance that New Mexico communities place on having the access to a range of childbirth services, because after all, that's the end game here, right? Access in communities to the care that people want and need to be healthy and safe. So the specific aims were really to describe what motivates a commitment to rural and maternity care practice, and maybe also what hinders it, and to explore this community perspective with attention to the history and culture of birth in rural New Mexico, which has been well documented and really is actually well known in other parts of the country as well, and something that we look to as a model. And again, with the study coming out saying that we're second in the nation for midwifery integration, really sort of represent a model where midwives are an important resource, or at least maybe we think maybe they are. I'd like to think we are, but I wanted to know what communities had to say about that. As an ethnographic study, my primary data came from semi-structured interviews. I had interview guides that were approved by my committee and the institutional, or the HARCO office, Institutional Review Board, for clinicians, community women, and community leaders. And these are the number of distribution of folks that I spoke to. I also did focus field work. I did a lot of traveling in and through the focus communities, checking out places where people received healthcare, attending public meetings. I gave presentations to local health councils and engaged in dialogue with these stakeholders. And then I did archival research, looking closely at the workforce reports, other legislative reports and proposals, social media posts, and news media. There were certainly things in the media locally and nationally around access to maternity care during the time of my study. My sampling was stratified and purposeful, so I really went to each different provider type and tried to recruit people through my personal professional networks, through others, and then snowball sampling. People referred me to their colleagues, their partners, their neighbors, and that's how I was able to interview people in community. I recorded interviews and had them transcribed. I had software to organize. I did the analysis, but I had software to organize it. I was looking for themes, and I did line by line coding to pull out the main components of my research questions. But I was also looking for community voices, and I was also looking for representations of power dynamics because of the framework I was using, which I'm going to talk about next. But qualitative research is really different from quantitative research, but rigor is very important in qualitative studies, and this is how I assured rigor in my study. I validated personally, comparing it with the recordings, the transcriptions I received. I did my coding and consulted with my chair around how I coded interview transcripts to reach agreement about how I was doing that. I memoed to reflect on my own role as a midwife in this state and as really the instrument of research as a qualitative researcher. I established an audit trail for my coding decisions so I could see why I coded things certain ways or why I made certain things, subcodes to a different, to a broader issue. And I followed up with people sometimes with questions, providing transcripts to a few people who were interested in having them, and also using my insights I was getting interviews to guide some of my questioning in subsequent interviews. The theoretical framework I used is called critical medical anthropology. Now, critical theories, and there are a number of different ones and ways of looking at it, critical feminist theory, critical race theory, but critical theories have an explicit agenda. So I'm here to tell you I have an explicit analytic agenda around this research, and it is to address injustice and advocate for emancipatory social change. So it does start with the premise that something's wrong that needs to be fixed, and I own that agenda. And I was looking for and interested in having a framework that helped me explain that in an appropriate and scientific way. And critical medical anthropology was helpful to me because it really addresses to and focuses on political economy and the organization of maternity care. And it can demonstrate the relationships and interaction between contextual factors that influence maternity care provision. I came up with this model, which is an adaptation of a model, critical medical anthropology model, and then one that was also used in midwifery research to talk about how, the sites of activity are individual and possibly the sites of intervention, whether it be policy, training, happen at the individual level, and then at the institutional level where people are trained, the institutional level where people practice. And really, this all happens within a context that really is bounded by federal and state policy decisions and the economic organization of maternity care in our country. This is meant to be hierarchical. This, anybody with a graphic, I'm not a graphic designer, so there's a better way to represent this. This is not necessarily hierarchical, it's just I had to portray it in a certain kind of way, but these factors over here on the left side of the model are really the context within which all this takes place. We have the biomedical hegemony really does influence also the structure of healthcare. And in New Mexico, well, everywhere, but I was particularly attending to the historical context and community health in our state and how those things interact. And again, I could say more about that if people have questions. Here are the major findings that come out of my study. There are multi-level barriers that are pervasive across provider types, and they contribute to this maldistribution of providers that we see, where we have significant concentrations of resources in our urban and metropolitan communities. And that despite their cultural resonance and community appeal, midwives and midwifery models of care are undervalued and underrepresented in our rural systems, which is a little bit of a contradiction of the big finding, but that is what it looks like in our rural parts of our state. And something that the community taught me that wasn't necessarily explicitly how I was originally thinking about it was that perinatal support services are a critical complement to clinical care. They help to counteract the fragmentation of care in rural communities, and they really can't be seen as entirely separate from, the work of the person who catches the baby. There's a number of quotes in this, and I'm going to go quickly through some of them. But again, this is consistent with a critical medical anthropology framework, and this is consistent with what I found, that people are really working within a context where there is a lot of uncertainty. I had a provider say this in a very articulate way to me. She said, it's the same uncertainty that drives problems with healthcare, with insurance, and therefore with billing, and it really comes out in this feeling of like, how do we stay alive in terms of delivering care in the rural community? And are the dollars going to be there? They're going to be there next week, next year. It's really hard to innovate in that kind of mindset and that kind of reality. And then I was quite stunned when a hospital CEO told me that it's such a complicated system that the whole system needs to be deconstructed and reconstructed because there's so many legacy components. They don't even fit together very well. He said it's that joke about fixing the airplane while it's flying. It's really hard to do. He's trying to run a hospital, and all these things are kind of in flux while they have to keep services available. I said that I found that the barriers were pervasive across provider types. One of the ways that looks for obstetricians who do attend the vast majority of births in rural communities is that there's a lot of turnover. And at the time I was doing my study, there were 8 people really in place. 4 of them had a year or less in community, 2 of them maybe less than 5 years. There was really only one county that had an obstetrician in place that had like years of experience in that community. And that matters when you think also about what it takes to get up to speed and comfortable and make a commitment to staying in a rural community. And I thought that this quote from a physician, from an obstetrician, really also helped to demonstrate how this, this organization, it impacts all along the way. This physician told me at the academic medical center, a 24-hour anesthesia could do a C-section in 3 minutes. That is not the case here. So we train people in that context, but they have to go out to a different context where they have a different set of circumstances and resources. You get an emergent situation where you have 30 minutes before you can get a baby out. And this physician, you know, linked this to some of the hesitancy that people can have practicing in a rural area. Nurse midwives, there are none attending births in 2 of the 3 communities or counties where I did my research. 5 have been displaced by either practice closure or lack of local practice opportunities in the past 4 years. These are people who live in rural communities and commute into the city to work, or who trained with an absolute explicit agenda to serve their community. And, you know, that is something I think we need to think about in terms of resources we have available, but where those resources, how they end up where they are. Family medicine physicians are an essential rural health resource. It is very rare to find them attending births. And in my study territory, there are only 10 births in 1 community. I am not aware of family medicine physicians attending births outside of what would be considered metro areas, mostly associated with education programs. But yeah, I'll be corrected. But it feels very tenuous to them. And one of the issues is the payment model at play, because family medicine physicians are not exclusively, but to a large degree employed in our FQHC networks, which were designed to be able to provide care in underserved settings, but they have a payment model that is not consistent, does not jive with what it takes, with what it costs and the time involved in providing full scope maternity care. So there's a strong disincentive for the institutions that employ a lot of family medicine physicians. And then licensed midwives are actually present in all these counties, but they are really marginalized by systems, and it affects they're marginalized in terms of a lot of their relationship, their access to resources and reimbursement, and the relationship development, and that affects their integration with the local system and really their reach, you know, how many women they can serve. Some of this is explicitly around payments. They are paid very poorly. They receive a low reimbursement for the services that they provide, but they also practice within a model of care which is not consistent with how care is reimbursed, doing a lot of visits, spending a lot of time with people. So I did find more personal level barriers. There was concern about the quality of the school system. There was concern about work opportunities for partners. I could also argue that these barriers that manifested in really personal ways for people who are considering oral practice are also entirely related to the structures in place within our communities and the economies there, and how this impacts the educational system and the work opportunities. It also has to do with the on-call lifestyle. And again, I feel like this also has a real structural component to it. This midwife observed that really, you know, the culture of clinical practice has changed. And this person associated that with the devotion to medicine that people used to have. I wouldn't say that people have lost a devotion to practice, but people are working under a very different constraints than back in the day when, you know, a physician and his, we use that term deliberately, family would be out in a rural community and he could be on call forever and there was someone who was taking care of the home front. This isn't really how, you know, American families are operating very much anymore. And it really, I think, affects all, especially maternity care practice and the lifestyle that's involved. But there are more mechanisms to mitigate those factors in the metro areas and there are very few in our rural communities. I found that practice facilitators and incentive, the most important thing, this was across provider types, this was across, you know, whether folks were from communities or had been recruited from the outside, it was a commitment to practice in a rural community. People came into practice with that. So this is something we have to leverage with people. The people who are there have always wanted to do this, and it isn't so much about the incentive. It was not so much about loan repayment, but this is not me making an argument against loan repayment programs, which are very valuable to the people in place. However, we do have a dynamic established where often, you know, there will be a certain position within an organization that's kind of on a rotating, you know, however long the loan repayment commitment is. So I think, you know, since that isn't the major draw, we just need to think about where loan repayment fits into our to a whole comprehensive array of strategies for keeping people happy in their practice and supported in their practice. It's hard to do this in 30 minutes, but training. The training programs in this state, people understand very well, are designed to prepare a rural workforce. Providers didn't necessarily think that once they were there, that there was the same kind of attention to that there was coming in. So maybe there are things that we could do to really, when someone really, well, first of all, to help us really figure out who is just doing that, because they were told that's what you say in the interview, and who really has a heart for this work, and then how do we really nurture that throughout their training. I said another one of my major findings was around the marginalization of midwives despite their appeal. And so I want to say I found it, you know, that present, but looking a little bit different in each focus county. Rio Arriba County, no full scope practice opportunities for CNMs. Taos, you know, a sort of an iconic location of midwifery culture, and the Northern New Mexico Birth Center being for decades a site of this practice, was going to be reopened under the auspices of the hospital under very difficult financial circumstances. That plan did not move forward. That was not considered a priority. And unfortunately, that led to the layoff of employed LMs, which is one of the things that's very rare, is an employment opportunity within a health system for licensed midwives. That's an example of integration, but those midwives ended up being laid off without attending the course. So that currently is on indefinite hold. And then in San Miguel County, we had a 19-month OB unit closure that led to a practice closure and immediately displaced 3 midwives and closed down a practice and contributed to that massive part of the state that I demonstrated that where there was no services. Midwifery models of care do have strong cultural resonance. And this community advocate was talking to me about, you know, sort of seeing an increasing return to interest in midwifery care. I also want to be really clear that this is the midwifery care that is really able to be community responsive to meet women where they are. So this is very specifically, at least in this context, out of hospital midwifery. It's not that this is not possible for those of us who practice inpatient services, but again, part of what resonates about midwifery is when it is able to be practiced in a way that is really able to either come from the community or be really present in communities. And that's just not something we're leveraging on a system level. And then I was, again, you know, I really was looking to the community to tell me about the importance of physicians in the breast catching babies. Everyone talked to me in the same conversations about perinatal support services. And I really had to realize that this was like, people didn't make a distinction entirely. This community advocate was giving an example of a woman in a family specifically navigating substance use and pregnancy. That was the example. And was talking about a real world case where these contribute to a wraparound care model that they're able to establish
where this woman is working with the midwife, she's working with the doula, she's working with the peer counselor, she's got home visiting, and all together we're kind of staffing her to make sure that she's got what she needs in a community where services are otherwise pretty fragmented and overburdened. I'm not going to talk a lot about the opioid crisis because, again, that's another hour plus, but that's a really significant public health issue that we need to address that affects people at all levels, from their individuals and their families to the systems of care that we have, and the ability of providers and community to feel like they're being effective. And then, perinatal support services also provide opportunities for women to get involved in their communities and even have some employed work. And I was really impressed to see how people were engaged in that way. The woman who shared this with me talked about networking. She came from outside the community and was embraced in the community and found herself a postpartum mom with an employed role supporting other moms in a rural community in New Mexico. I feel like this is really a valuable service. All studies have limitations, and I also want to acknowledge them at a time. I'm going to go over a couple minutes, race through my recommendations. Qualitative research is not meant to be generalized. I studied 3 counties in northern New Mexico. I think pieces of this really resonate, but that's where I studied. So I'm not making claims that this is, that this applies across the board to rural communities throughout the United States. I was the instrument. The quality of the interviews had to do with rapport, they had to do with interviewing skills, among other things, but that was an important limitation of this study. And I am known, I have an identity as a certified nurse midwife, and was known that way to many of my participants. The range of participants in the counties I might have found out different things in other areas. And I was not as in traditional anthropologic methods, living as a member of communities, embedded in community for an extended period of time. I was doing more of a focused ethnographic approach, which is becoming more common, but I was spending a lot of time in community, but I wasn't living there practicing in those communities. It's a limitation. And then, I have an explicit critical agenda to address inequity, and there's inherently researcher bias that we have to contend with, which applies to quantitative studies as well, but I want to own that in this case. This participant told me that women are not going to come to a community if they can't have children here. They're going to shift to an older population. She sold real estate, so she was able to tell me that from her perspective as someone who was trying to sell houses and who she was able to interact with. She happened to live near the community where the hospital was closed, and so that was a real world experiment for her, and she saw a shift. So this is a matter of community survival as well, I would argue. I have some recommendations, and I'm just going to state these. You can ask me questions about them. I'm happy to talk about them. They do come, out of everything people shared with me. But, it's hard to do any kind of research around healthcare delivery that isn't going to come up with a recommendation that we need payment reform. This is a federal issue. It's also a state issue, and it manifests in specific ways, but payment reform. Workforce tracking, my very specific and bounded recommendation is, can we please ask people if they catch babies? It will also help us quantify the role of family medicine physicians, which isn't even included in our workforce report, kind of in the women's healthcare workforce, because we just don't have a way to quantify what they do. But if we knew who caught babies, that would give us another lens and another map to show, kind of what the real situation is. And we need to figure out how to address the disincentivization in the FQHC model around the provision of maternity care. Also, when that hospital closed for 19 months, they did it with 6 days notice to community and staff. And I would be interested in a conversation around, are there any levers to at least require a process that might slow down that kind of decision making, or at least help first responders, pregnant families, and providers prepare. And we need to include licensed midwives in the practice incentives if they're willing to meet the requirements that are otherwise required of people who earn these practice incentives. If they're able to play a role in increasing access to care and broadening our network, they should have access to the same resources that we provide to other provider types. I think there are ways to have a more robust track for people who want to be prepared for rural practice. It seems like an excellent interprofessional opportunity to me. There are very few components of that that would be really disciplinary specific, like a conversation that only OB surgeons need to have. So much of this could be a real, like a seminar that's multidisciplinary. And I think in midwifery, we need to have a conversation about preparing people for, if you really want to join rural practice, do you enter a program where you get a dual certification from the outset? Because you need a broad skill set to be useful and employable in these communities. And I think this is one of the things to see. I'm gonna skip over that. And then, there are many types of research, many different directions to go with following up on our workforce data, with following up on policy proposals. My personal research agenda involves, prioritizing community-led and community-engaged projects, because I believe there are people in these communities with tremendous expertise and some resources, maybe not necessarily the same resources I have to get their questions answered, and I want to work with that. And then there are also innovative care models out there that I would like to see their effectiveness documented a little bit, so that we can add that to the conversation about what role they play and how we can support those to increase access. Again, this is the same person who gave me the title of this talk, and I just feel like this sums it all up. How do we come back to what we've known and come back to a model that was working before whatever happened? It's people who live in community, caring for their own community, who have obtained the education to come and do that. I feel like that's going to be more of a lasting solution than just peace. So how do we get there? That's something I'm interested in. And I apologize.